Yeah. So I raised a question maybe a take-home message for all the radiation oncology or all oncology in this field. To breast cancer, head neck, advanced esophageal cancer, I do believe the overall survival in every institution may be below to 20% or less than that. Should we treat so comprehensive from scar-based to CD-trunk at least 4 weeks or 5 weeks of electric treatment or radiation and boost to the tumor to 7 weeks to 5 weeks to 6 weeks? Yeah. This doesn't find say, so talk about is patient tolerable and is patient feasible, is it really benefit to the patients. All right. The third question.
So your question is about patient with synchronous cases or all cases?
It's during whole treatment in hospital. Or
So patients who are treated by large field, of course, under mission. So very early case of cancer like laryngeal T1, they are we use just radiation. So in that case, they are treated in a patient group.
So in Taiwan, in Cheng Kung Memorial Hospital, because the patient burden is huge, so we let patient receive radiation therapy in outpatient basement. So go and forth every day, and we have a lot of oncology patients in hospital. So we cannot, such as this case, we have a waiting time for machine for radiation. Next time, waiting time for admission for chemotherapy. So it's a make a lot of trouble, especially as our experience. When patient during concurrent chemoradiotherapy, nutrition is also, and fluid resuscitation is highly important on this patient group. So if a patient can admit for the whole course, I think probably the outcome may be better. Another question, such as we just talked about the large field. Personally, I agree to the two-stage radiation, but our chairman, Professor Zhang, he always give us one field. As our experience, such as the present case, we have limited radiation oncology knowledge. If we focus in the head neck main tumor and the other one is esophagus, as my assumption, such as iso dose curve in head neck, probably not enough for esophageal cancer. Sometimes we focus on the esophagus, it will spare some head neck area. So in my clinical experience, previous we have both cancer. We can see such as this kind very good response to head neck cancer for the esophagus only partial. And sometimes the esophagus lymph node, mediastinal, total regression, but esophagus just regression a little, but the head neck quite good. So probably I think that the two-stage radiation probably may solve this problem. But I think it should be proved or confirmed by the clinical study. As I know that I saw the chairman, Professor Zhang, is not his head. Probably next time we will get 2 stages treatment for both people.
Yeah, Dr. Feng will raise the post-bed study for this kind of cancer.
So I think it's a good opportunity to have different opinions from different centers and different specialties. So we still have 8 minutes to go. So any other questions regarding please? Please.
Yes, I'm Dave Bao from Cheng Kung Memorial Hospital. I'm a laryngologist and head and neck surgeon. I want to ask my ENT colleagues. From the 3 different talks from our surgeons talk, we know the treatment outcomes it is quite different from our Japanese data and from Taiwanese data. But yeah, that's the horrible truth we know. Yeah, yeah, you have to forgive us. That's the horrible truth in Taiwan. Not only the outcome is relatively poor in Taiwan, but the treatment failure pattern is different from Japanese. Yeah, from Dr. Jen's review and our own opinion, yeah, the hypopharyngeal failure will be a big problem for us, but not in the Japanese data recent this afternoon. So I want to ask my Japanese friend, will you have some opinion for us to change our treatment strategy, or I don't know, based on your surgical suggestion, should the surgeon do more on this field?
You mean so regarding hypopharynx?
Hypopharynx.
For example, so my philosophy is tumors that cannot be respond to the chemotherapy or injection CCLP, they are not cured by CCLP. How strong we intensify the treatment modality? So that kind of patient can be better treated by surgery, I think. I'm a surgeon, so that is the advantage of surgery. So as I mentioned in my talk, so our philosophy is use induction CCLP as a selection tool for organ preservation. So patient responded well will be cured by CCLP alone. But the patient who didn't respond well cannot be cured by CCLP. So they should be treated by surgery. They'll give the early phase of treatment, probably, so this might prevent distant metastasis, things like that. So that's our philosophy. And I don't know this is true, but it seems like what we are so far, I think. It's okay?
I want to listen to the opinion from Taiwanese.
Actually, the average survival rate in Taiwan is very honest. And actually, in the past, we think about the organ preservation, and most of the patients actually lost their larynx. So in our institute, we try to perform the concept of the organ preservation. We just perform the downstage of the tumor by CCRD, and then try to plan the surgery for the residual tumor. Actually, in the recent data, we show that the survival chance will be much better. So I think no matter what you try to run the primary tumor radiation or the primary surgery, actually, the surgeon still play a major role in this disease.
And so the majority of the patient will get good result of the survival, maybe receive surgery. But I think that because the cancer patient burden were very high in our country or in every hospital. But I think that if every hypopharyngeal cancer was diagnosed, please perform the endoscope or confirm if there are any early esophageal cancer within, because of both early or the early esophageal cancer was treated with good survival.
I agree with you, and as in our institute now, for a lot of early hypopharyngeal cancer, we perform some conservative endoscope resection. So that is another idea of organ preservation trial. Not only we use the chemoradiation, but we can use some advanced and novel tool to do the organ preservation surgery. I think this can provide a lot of benefit for our patients. I saw from Dr. Sudas show your case is the 42-year-old female with the tongue-based cancer. I saw your data. You didn't do the mandible split, just do the transfer. Am I right? It is quite different from what we do in Taiwan.
In my opinion, so most of the tunic of the oropharynx, well, probably part of nasal cancer can be a push loop without mandible split. As you know, so many very big oropharyngeal tunic can be removal from cervical approaches. So if you experience more transcervical approaches, you can cut through the rubber lateral pharyngeal wall up to nasopharynx. You can cut through from the body. So it's my opinion. So during the last 10 years, I have never experienced multiple sclerosis. Yeah.
I think time is up. So we still have lots of time to discuss.